Hello, everyone. Thank you for your patience. Going to get started in 1 second. Sorry, we're having some technical issues. I apologize. Just to save some time, I'm just going to, my name is Matt Beyerschmidt. I'm going to start sharing my screen at this point. There we go. All right. So again, thank you for joining us for the second session of the Public Housing and Partnership, a Resource Toolkit Learning Collaborative. We are, again, starting our second session today. My name is Matt Beyerschmidt. I am Senior Program Manager at the National Nurse-Led Care Consortium. Some housekeeping matters. To adjust or remove captions, click the live transcript button at the bottom of the Zoom window and select hide subtitle or show subtitle. Feel free to ask questions. Please add your questions to the speaker and the comments for the group and for the speaker and comments for the group into the chat box. Technical issues, please raise your hands and let us know, and we'll message you directly. And just so you know that we are recording the session and will be available with all the supporting materials after the session. This session is divided into 3 main sections. Between each section is a short knowledge check. Participants can complete the module at their own pace. Time to completion is approximately 60 minutes. A little background on this partnership between the National Nurse-Led Care Consortium and NCHPH. National Nurse-Led Care Consortium is a membership organization that supports nurse-led care and nurses at the front lines of care. And NNCC provides expertise to support comprehensive community-based primary care, specifically policy research and advocacy, technical assistance and support, and direct nurse-led care services. The National Center for Health and Public Housing, NCHPH, is their mission of the National Center for Health and Public Housing is to strengthen the capacity of federally funded public housing, primary care, health centers, and other health center guarantees by providing training and range of technical assistance. NCHPH and NNCC are both NTAPs, which are National Training and Technical Assistance Partnership. And we work together today to provide you this learning collaborative. We will be sending out a CE link after the completion of this session, so you can get approximately 1 hour, which equals 1 CE credit for attending and completing the quiz of the session. And I think I just repeated this slide. And then I believe that's it, right? So I'm going to now pass it over to Dr. Lombardi to kick off the session. And that's about it. Thank you for joining us. Thank you for your patience in the beginning. This is the right slide, correct, Kevin?
I'm sorry, muted. If you could go directly to the learning objectives slide, please.
Oh, wait a minute. I opened the wrong one. No. I opened the wrong one.
Yeah, if you Matt, if you want to just grab the session I just sent you via email and open that.
I thought I did. I thought I made that one pretty. This one? This.
There we are.
All
yeah.
Right, cool.
Oh, you did. It looks great. Good afternoon. My name is Dr. Kevin Lombardi. I'm a medical doctor and epidemiologist. I currently serve as manager of health research policy and advocacy at the National Center for Health and Public Housing. Thank you for joining us today. In keeping with the spirit of this LC and in the interest of giving the most high yield information as we can, we are forming our session around a series of discussion questions based on our toolkit. I'd like to encourage you all to ask questions and participate as much as possible. We are all struggling with a lot of the same issues, and your questions often allow us to introduce additional perspective to all of our benefit. Our guests today will be, we'll have Jason from HUD back to visit us again, and Dr. Asante Hiltz will be joining us shortly from Valley Health in Columbus, Georgia. To briefly go over our learning objectives, we'll be staging these questions one by one, and I have a variety of questions for our guests, but we'll be addressing effective methods of communication within collaborations, the involvement of stakeholders in collaboration, specifically how to do that and how to manage that, collaborations with community organizations, evaluating partnership programs and the roles and responsibilities that different partner organizations should and can have in those evaluations. And in the interest of ongoing issues, public health emergency transitions and partnerships and their role. Next, please. Just a reminder that this is based on our toolkit. I will briefly pop in the link to that. The section we will be going through today is module 2. Okay, and there it is. Okay, so the toolkit goes over a range of personal skills that are important in forming collaborations. Today, we'll be taking advantage of the continued availability of our experts to take a deep delve into the material in module 2. So the module goes through a variety of listening, written communication, and verbal communication skills that are worth looking through and reflecting on. And today, just to talk a little bit about how to make those skills work when the rubber hits the road. I'm going to start by introducing questions specifically to our guests. I would ask that you please drop your questions in the chat box if you have them, or raise your hand, or sort of whatever method is most comfortable to you. What works best for that, Matt?
Repeat your question, Kevin. I'm sorry. What'd you say?
For the questions, should they pop them into the chat, and then we can go ahead and read those?
Yeah, they can pop into the chat. They can feel free to unmute themselves as well if they have questions, whatever they're comfortable with, and we'll be monitoring both.
Okay, so first question for you, Jason. Do you have a perspective on longstanding collaborations? Specifically, last week, Latrice and Ashante told us the example of the WIC program that they made. And essentially, over the years, they were able to, over the lifespan of the program, they were able to find an existing issue, collaborate to address that issue, and then build services on top of that, specifically the dental services and so forth that they introduced after the WIC program in mobile units. Do you have a perspective on long-staging collaborations and how those can evolve?
Yeah, absolutely. You can hear me okay, right?
Yes.
Great. Well, you know, I really love the example and sort of the approach that the toolkit takes. So I might just share, you know, we've often seen that partnership, one of the hardest things is just getting off the ground. And so finding some easy victories, some kind of early victories, low-hanging fruit. So the example that we used to use was around flu vaccination. And, you know, that was something that you can get people in the door. You might be able to then sign them up if they don't already have a patient home. Right, so it's a win-win. Provides them with the service that they're needing, and it provides you with an opportunity to engage a population that you might not otherwise see. And so, you know, I try to think about the collaborations I've seen have often started with, you know, something like a flu shot, a food distribution, you know, something where the ask is really light, and you're not really having to do a lot of logistics, so there aren't a lot of moving parts and pieces. But then, you know, building from that, we often see, well, from there, you know, you start to have regular meetings and say, well, what if we try a community health worker program? Or what if we build on flu vaccination and try and do catch-up vaccinations for youth? Or, you know, what if we just try and take it to the next level? So in my mind, you know, if you start small and then, you know, even if it fails, right, you can still take what you learn from that experience and say, okay, next time, how do we want to do this differently? What do we want to take from this experience? And how can we continue to build a collaboration? Plus, I mean, you have the benefit of now you know who you're working with, you understand each other's styles, and you sort of have a better sense of each organization. So at least I tend to find most long-term collaborations I've seen started from something like a flu vaccination drive or a food distribution drive or a back to school event, just because, that was a really easy way to get started.
Mm. So, like, when you're talking about, you mentioned regular meetings in an interesting way, because it discusses it almost as if it's kind of a form of infrastructure. And if I can take your example and look at, say, a health center in a small community organization works on a food drive or something of the sort, and the health center would to provide, say, funding and some of the staff, and the community organization would provide a space for them to deliver the services. If they were engaging in regular meetings with that provides a opportunity to grow the relationship through that existing infrastructure. Is that sort of what you're getting at?
Yeah, and I think, so just to kind of take it to the HUD context, the program I help run, the Family Self-Sufficiency Program, FSS, I might have mentioned this last week, one of the core components that we require from our grantees is something that we call a program coordinating committee, or a PCC. Now, what that is essentially just a group of partners from the community that get together on a regular basis, could be quarterly, could be monthly, could be weekly, and it's focused around the needs of the community and how to meet those needs from each different service provider's sort of point of view. And so I think what I've often seen is, getting that initial convening together, getting those folks in the room the first time can be really challenging. But once you have them in the room, then, hey, if it's working, let's do this again, right? Let's meet up again next month, or, maybe let's do it at a different site, or let's do it at your space next time. But I think getting that collaboration started, and you're right, it then becomes part of the infrastructure where you can lean on each other and say, I have this person's number, I'm just texting them now, I'm not doing a cold call. It helps, get the collaboration going in a way where you don't have all the friction of initially not knowing who you're working with and what their working styles are, and really what their organizational needs are.
I mean, I think you bring up an interesting point there, Jason, and it's something I've recognized in early stage collaborations that I've engaged with is that the early relationship building, it takes a great deal of time. When, say, a point person at one organization is the set communication for a point person at another organization, and it's sort of just one-to-one communication, even that can take a lot of time, getting to know their personalities, their preferred communication style, and so forth. And if you look at it from that perspective, the more people from each individual organization that are communicating, the more complex that gets. And I like the way you describe that, because it really describes these collaborations and this social relationship that goes behind them as what they are, is they really are a form of infrastructure that that health centers need to build and invest in. What are your thoughts on that perspective?
Yeah, I mean, I see Rod's hand up, but I think you just made me think about another piece of this, which is it's also building trust, right? So part of, I think, all of these sort of collaborations are built on mutual trust, and the idea that, okay, if I'm going to invest my time for your goals, which might be different than my goals, are you going to do the same for us? And so, part of the, I think, beauty of doing something where it's a low risk, low ask, is that, you both get that benefit. You can see where you come through for the other person and the other organization, and then, you continue to build on that positive trust. I think one of the areas where I've seen sort of these things break down is where, you start to feel like, well, I can't rely on this partner. They might commit to something, they don't show up, they don't follow through. And, sometimes that just is maybe a mismatch of expectations, or maybe, there isn't sufficient leadership buy-in or resource allocation. But I think, building that trust is really essential. And it's, in my mind, all the more reason to start small, where it's very achievable before you get too ambitious.
You make a couple of points that I want to get back to there, but I think you mentioned, Rod, I think you have an emoji on your icon. So I was wondering what your question was.
Yeah, so I'm just curious, as I'm listening, a fundamental question that comes to mind for me that I hadn't thought about before, which I probably should have years ago, but from a public housing perspective, staffing wise, is there core competencies that public housing staff are given when they hire in related to things like social determinants of health, or looking at, understanding residents living there through, this type of context of social determinants of health, and the importance of working with community partners to support residents living there and so on?
Hmm.
Yeah, I think it's a great question. And, this is one area where I would say, sadly, I think as the federal government, we've lagged behind state and local partners on this, because for years, folks on the ground were saying, hey, we really see the essential linkages between health and housing, particularly around the social determinants of health. And I think there was maybe a delay, sadly, from the federal level of saying, yeah, we see this too, we value this too. I think now there's a deep recognition of that. It's gone across administrations, but it doesn't always mean on the ground, it's the same person you're going to talk to. It's not, we don't, have like a dedicated person that we fund at every PHA. I wish we did. But usually what I can say is there's somebody who, whether by just personal interest or background or affinity, has really taken this on. So to give an example, we worked with the Housing Authority on our community health worker program, linking the Housing Authority with the health partner. And at the time, the person leading this initiative was in charge of a workforce program, but they had a deep interest in health. And having established that program, they then actually got promoted into a position where they're now in charge of resident health initiatives at the PHA. So, a lot of times folks who have this understanding on the ground, they may be trying to also establish the buy-in from their leadership to really dedicate the resources on this. And, that might be one of the things that they're looking from you all, is to help show the value of those partnerships. Because I think, once leadership sees, hey, well, this is the benefit, then they're much more likely to dedicate the staff time.
Thank you.
Did you have a follow-up on that, Rod?
No, it's just, again, I'm trying to think through this. The community we serve here in Michigan, Albion, is 7,500 people. We've got a number of public housing complexes here. We have community health workers where we're already doing work, but it just, it reminds me, like what you're saying, of the importance of, and even though I talk with the managers from time to time, I haven't probably been as intentional in terms of building the trust and really just sitting down over coffee and talking about, how can we be more intentional about moving some of these things forward. So this is good stuff to think about.
Yeah, the interesting thing, I was reflecting on this with a colleague recently, Rod, is I think we're heading into a direction where there's a renewed focus on the personal and on communication in person where it's appropriate. I think the issue that a lot of us are running into is that our schedules can often not permit that, and it's a huge investment of time. And it is, when I try to balance this myself, I try to take a more structured approach to it and kind of think of it as a budget and apply a sort of a understood amount, whatever you may find appropriate or anyone may find appropriate to that, and budget it in every week. Have a roving coffee date on Thursday at 2 perhaps. But I think another one of the difficult aspects of that is we're all, evaluated either internally or externally for our time. And the rapport that you build in these relationships is something that pays off very well over time. Sometimes we can, when we're focused on more short-term things in management of our facility, that can fall by the side very naturally. So it is a difficult balance. Dr. Hiltz, do you mind if I send you a couple of questions on this this topic?
Yes, I'm in now.
We have her. So we're starting with the concept of sort of communication and professional rapport is kind of where we ended up going. And the reason I wanted the conversation to go in this direction is because of the example you gave us last week, in that we had what appears to be a very effective professional rapport between you and your colleagues. And I guess my question is that something that is the result of this collaboration, or was this something that was built on with either previous efforts or even personal relationships?
So I'm going to speak on behalf of myself and Latrice Johnson, who was here last week from WIC, because she's not able to come. and share that the initiation of the partnership with the Housing Authority really was because there was a need on the program side. So for example, the WIC program, sort of like what Latrice shared last week, is that they realized they really weren't serving the community as effectively as they could. You weren't seeing the numbers that they needed to see. And there's a lot of barriers for women getting the assistance that they need, families, not just women. And so we identified that among the community partners that are there, other service providers serving a lot of the same families. So the Housing Authority was one of those. We reached out to them to say, hey, you have a subset of our population that we serve that we think will be great for us to bring our mobile unit over to serve those families. And does that work for you? I think in terms of a sustainable relationship, though, past that initial arrangement is the number one, the consistency, like Rob talked about, making it intentional with meeting. But one of the ways to do that is to say, can you have a public health representative on your community service board, or your monthly partner or quarterly partner engagement meetings? And then on our public health board, can we have a representative from housing on that board? Because oftentimes public health isn't represented on many of those collaborative boards, like the opioid use. Now, finally, public health has been invited to that table. Housing, we want to be invited to that table. Mental health, we want to be invited. So we're trying to kind of force those relationships that may be non-traditional, make them more common. And housing for us is just a natural fit from a public health perspective.
Well, I mean, from the perspective that Jason just brought up, he discussed these things as sort of like an infrastructure. And I think what you're describing there is even a step further when organizations have reciprocity agreements to put individuals on each other's boards or within organization to have expanded membership so that folks are actually sitting at the table with each other. If you can think of a weekly meeting and something like this as well as in shared responsibilities, in a way, it seems like they provide an infrastructure to build on. So when there are opportunities for ideas or expansion of programs, there's a place to bring it up in the first place. Matt, if we could transition to question 2, please. I'm sorry, does anyone have any questions or comments about collaboration before we transition to stakeholder involvement?
Can I make a comment? This is Jonathan Evans.
Please.
With the Columbus Housing Authority. And I just wanted to comment because, like Dr. Hills was saying, we do like, collaborating with health workers. We actually try to bring a lot of the health workers to our properties. We call a mobile unit here, which the Department of Public Health has one. And then we have another hospital here, which is Piedmont, which comes in. And I was talking to someone the other day. We understand the importance of having help, people to be able to come in and talk to our residents. One of the things that we've done, which is another company here, which is Mercy Med, which they work off of a sliding scale, which they, if you're lower income, it goes by just by your income. And we've actually put a Mercy Med office in one of our facilities. Which is it's a trial thing. We just want to see if it's going to help, because we have kids who are, they can't go to school on certain days, and the parents can't get them to the hospital or to the doctors. And so we're wanting to see if it's going to help to have that facility on site, so that that person or those persons can go right across the street, which is in their community, to use that health facility. So we see the importance of it in housing for sure.
And Jonathan, if I could ask you a question about that. You mentioned Mercy Med is having a physical location in one of your facilities, and that it's a trial. What was the discussion behind that? Was there did that arrangement come from any previous involvement?
Yes. Our CEO, what she decided was she works with a board that is actually, I forgot the name of the board. I want to call it the Mill Village Board. And they all got together from the community, and they were talking about things that they saw that they may need, because we tore down this community, which was Chase Home. We demolished it and rebuilt.
Okay.
So after the rebuilding, one of the things that they agreed upon was, hey, if Mercy Med got with us saying, can we put a, facility there on site? So they actually, during the building of that property, they actually built a physical, area for Mercy Med. They can bring in all the equipment and they can be there, and it's like a area that rented out to them, but it's not really rented to them. It's just something that we've incorporated on site so they can use.
I see. So, this is sort of an evolution.
Let me just, can I just add on to that comment real quick, Kevin? Just
please.
to help you understand why what Jonathan has said is so important. And it's just, I got goosebumps when he's talking about it, because Mercy Med is a FQHC lookalike.
Okay.
And so moving beyond just bringing the mobile unit to the housing authority, they have the gold standard of having an actual building, carve out inside of the housing unit, which is like same thing that we're doing with the school-based health center. So we actually have a clinic inside the school, making it even easier and more accessible to bring services to those children. That's what Mercy Med as the FQHC lookalike is doing. They're right there in the housing complex, so those families can get access to that care even easier. So it's increasing accessibility of care.
So, it looks like there were some serious steps in moving this relationship forward, though, and it seems like this is a pilot, if I'm correct. Jonathan, is that correct?
That is correct. And then with our board and with our CEO, those are things that they look at. Another thing that they're actually looking into, which is, I don't want to say they're going to do it, but one of the things they're looking into is also putting maybe a child care, having something that looks, form of a real child care on one of our sites also. So the parents who can't get to work because they say, hey, I don't have child care. So they're looking at doing different things like that so that we can try to overcome a lot of those barriers that our residents are having. And then one of the barriers is the health care, where, you have this child that says, Mom, I have a sore throat. Instead of just keeping them home, not knowing if they have strep or whatever, taking them to that facility to see if they're strep throat. Hey, let's do what we need to in order to get them some medication so the whole family won't have it.
And just a follow-up on that, if you don't mind. What's the plan with the pilot? Do you guys have a defined pilot agreement or a pilot program, defined pilot program, or is this more informal? And if you don't mind sharing those details with us.
It's not like a real, we are looking for it to go long term. And we're just, of course we have that area for them. Now that's going to be solely up to Mercy Med. If we have this going and Mercy Med sees to where it's really not benefiting, they can pull out, as well as we can say, hey, we just have this area here which no one is using and nobody's actually taking advantage of. But that is something that both sides can look at. But that's the reason I say it's like a trial. But we're not looking for it to ever stop. We want it to be there forever. But of course, if it's not going to be useful, then of course you don't want to just have that building just sitting there and not being utilized.
This goes to I think a really important point is I think we need to be very mindful when we're creating these relationships. And when I'm seeing how you're discussing the steps forward in solidifying the relationship, in the hope that these services will be provided on a permanent basis, but with an understanding that we need a trial basis to see how this is going to impact our workflow, impact our us financially, and so forth. I think these are all questions that any partner is asking themselves when they're thinking of a collaboration. And what I like about this is it's an honest way of giving that a try with good intentions. So I wish you the best of luck. That sounds like an incredible program. And transitions very well to the next subject, which is really you addressed in an interesting way, because you were talking about the community being an important aspect of inspiring where programs are going. and in providing data about what the needs are of the community and so forth. And I wanted to talk a little bit about that. I'd like to get some thoughts about collaborations in general. And I'd like to get Jason's perspective on what he sees as like as the HUD perspective of having these sorts of relationships. And so specifically, Jason, if I have you, what's your, do you have a perspective on stakeholder involvement in community organizations before I have some more specific questions for you? Jason, did we lose you?
Can you hear me?
I can, yes.
Okay. I think one of the key ways to do this is actually reciprocity. So what we often see is an arrangement where, maybe you have executives serving on each other's boards, or, residents serving on advisory committees or boards for other organizations. I think, having like a formal MOU is often a gold standard, but it's hard to start from that place. So I think, some of the early collaboration around stakeholder management, I think, comes from finding the right person. And at least from the HUD perspective, and I think I mentioned this last week, for health, we actually have a program, the ROSS program, the Resident Opportunities and Self-Sufficiency Program, ROSS. And we fund sites there who have, I think among the options they can choose from is to focus on health. And for the ones that do, they have a dedicated interest, right? They've got to meet their metrics in terms of referring people to health partners, having follow through, positive outcomes. And so they have a built-in interest. And if you have a built-in interest, it can start from there. But then eventually, I guess the hope is, we get to the point of having, leadership and reciprocity at those levels. And I often think of it in terms of that pyramid, where you start with just sort of like keeping each other aware of things, right? Just like communication. And then at the highest levels, you build up toward really deep collaboration where you're actually, working on projects together and sharing information and, finding opportunities to benefit one another in your work. So I think that's kind of one of the ways, and it's not the only program. There's also the multifamily service coordinator program for senior disabled housing. We have other programs as well, but I think it's just knowing sort of what are the programs at your housing partner or agency, and where can you plug in, who over there has the built-in incentive to work with you.
Jason, I have some follow-up questions about your perspective on MOUs, but we have a couple of questions. Rod, I'll start with you if you don't mind, and then David B will go to you after. But Rod, if you could you share your question with us, please?
Sure. I'm just thinking about, again, stakeholders, partners, et cetera. And so when along the lines of this conversation, when we think about the local health system or health systems, and again, the ongoing evolution of value-based payment systems and the need for health systems to be able to collaborate more in the community, I'm just curious to get perspectives on how you're including your local health systems in these partnerships, these conversations, as it relates to HUD residents and more support within the structure of the housing, et cetera.
Yeah, I mean, it's a great point. And I think, so traditionally, things like fee for service didn't really give us a lot of leeway when it came to, community health workers, right? It's often hard to find like a billing code that you can put that down. Now, I think we've been advocating for SDOH billing codes and the Z codes, and there's been some movement there maybe, but I think in a broader sense, when you start to look toward other models where, we did, for example, with the community health worker programs at our Jobs Plus sites, where you can measure the value in other ways and make an organizational case for why the collaboration actually benefits the organization, to the point where you're willing to dedicate your resources toward it, right? That's kind of the gold standard. But I wish there was a ready set pot of funding in housing to spend on health initiatives. There isn't, but there are operating funds and resources that could potentially be used, but it's at the discretion of the PHA, and so you have to make that case for each other, right? And that's why we often find, some arrangement where it's a match or 50-50. I think from a lot of housing perspective side, they look at it and say, well, wait a second, we have health centers here. They're funded under the public housing primary care program. So, shouldn't they be serving us, right? Isn't that what those funds are for? And so I think when you sometimes see the breakdown, it's just, you all know those funds are spoken for, our funds are spoken for. So where are we going to find the resources to make something greater happen? And I think it can happen if you can make the value case, to your leadership, or even just start something small that shows that this is worthwhile.
Appreciate that perspective, Jason. Rod, did you have a follow-up?
No.
Thank you. And David B., I think you had a question there as well. Is there anything you'd like to share with us?
Yeah, it's about this program needs wait for a long time. The people may receive the services after a long time. So the majority opinions about all this program is that is the results is not fast, it's not quickly, and the people need support as soon as possible. So what manage the time about these programs? This is my question.
So, I mean, to restate here, you're looking at the management of long-term relationships, and specifically about the time investment in maintaining and growing those relationships. Am I correct?
Correct.
And could you repeat your question, please?
Well, let me just say, I mean, if I think I understand the question correctly, there are often what we hear is, well, we can't get in touch with somebody, or we can't get anyone to answer our calls, right? Folks are busy on both sides. And this is where I think we really find the value of on-site services to be supreme. So, you might say, oh, well, I have a clinic down the street, people can come here, right? And maybe that's true, right? Maybe that is the case, but what are the barriers to that? Is there a transportation barrier? Is there just the time involved? Is there maybe some discomfort? Is there even like scheduling concerns? So, even if it's one day a week, right, having something on site, co-located services, I think can really be transformative. And so when we say in or immediately near public housing, there's a huge difference, a massive gulf between in and immediately near, and what do we consider immediately near? So, one way to sort of, I think, make the most of the time commitment is to say, hey, I'm going to be on site providing services, and that's another chance to also connect and build a relationship with the partner. And then you're not trying to track someone down on the phone, or getting their voicemail, but you're there on site and you have a presence. Obviously, that's a gold standard, and if you can't do that, there are other ways to build a relationship. But I think, oftentimes it is really important to get the initial sort of relationship established, so you don't just feel like you haven't been able to make that connection.
I mean, you make an interesting point there, Jason, is that I think sometimes we forget that in and immediate and near are definitions that are based on sort of our definitions of space, and that these can be significant barriers actually on the ground, and they look very different. David, looking at your question in the text, and with regard to emotional qualifications, and perhaps I think that's when we were talking about the SDOH and standardization. I think seeing it as a core competency is something that I've seen over the years change quite a bit since beginning of medical school to now. The importance of that subject academically has gone up significantly. So I know it's increasingly a part of the educational apparatus, and I think what we may see in future years is it getting baked into the accountability of the system more and more. And I think that's more as a core competency of understanding, as like more of a conceptual framework than necessarily a way of interpreting events or making decisions. But again, on stakeholder management, one moment, let's get to my text here. Regarding stakeholder management, Dr. Hiltz, may I present you a question, please?
Yes, sir.
Regarding stakeholder management, I was wondering if you had a perspective to offer with stakeholder management. Specifically, is this something that you have like defined processes that you have in mind when you're looking to engage in it? Or is it something that's done more on a case-by-case basis?
Thus far, it's been done more on a case-by-case basis. Hopefully, we have established some systems that can be replicated and we can formalize them more. Like, for example, just standard, usually if you're going to have an agreement with another organization, you might first sit down with them and create an MOU. Well, a lot of these agencies that we work with to bring our mobile unit on, it's been very informal. Hey, can we just try it out? Can we bring the mobile unit, see if the public are receptive to it? Let's try it. So we have not gone that formal route of creating an agreement between the two entities. And then other places we've done that. So I think getting a consistent approach is going to make sense going forward, because then it will allow you, when you write that agreement, here's an understanding between both parties. It becomes more formalized. It allows us to be bedded into each other's agencies a little bit more formally, and that probably protects us a little bit better. Like if somebody leaves an organization and then that communication that they had with the one individual is no longer there, but the agency itself didn't have a formal agreement, and then you might lose that relationship because it was attached to one person.
And you bring up the MOU again, and this is a question for you and for Jason, either one. At what point do you think is an appropriate part of the relationship to introduce the MOU? And I understand this is a difficult thing to standardize, but I was wondering if either of you had thoughts on that.
Well, I mean, let me share, and then I'm curious, the perspective on the ground. I think every organization has a different process, but typically, I think when organizations require like board approval or executive sign off, I mean, that can be really good, right? Because it gives you something to ground the relationship in and say, hey, we have this buy-in, but that can take time. And so I often think about when I've worked even with our leadership, they're not the ones on the ground doing the work. They want to understand, well, what is it that this is going to accomplish? So it's partially, I think the time is right when we built the case internally on both sides to get the leadership buy-in. Where you haven't done that, I often see, geez, this thing could sit for years, right? And nothing could get acted upon. So, I think it's a determination you have to make with your own internal stakeholders and then collaboratively with one another to say, hey, are we at a point where we think this is going to move forward? And, let's say you want to do something there around data sharing or public health information sharing, which would be great. Oftentimes, lawyers get involved just because they want to make sure there's no, publicly, personally identifiable information and, those kind of things. So it can take time, and I wouldn't let that process stand in the way of all the collaboration that could happen, even without an MOU. But I think an MOU is a good way of institutionalizing a relationship, but it's only as good as the paper it's written on. So, you can have an MOU, and if nobody cares, then it doesn't mean anything, right? So it does require, I think, real things to continue happening on the ground. And so in that sense, you almost don't need it, but it is, I think, a really nice thing to have. And it also can show, your local political leaders that this is real and that maybe there's a need for funding.
Yeah, some thoughts on that, Jason. I agree with your perspective. I think one of the challenges that I personally run into is when working with smaller or informal organizations, the MOU can be difficult to introduce early on, and that there's sort of an initial period of rapport building that has to be created and invested in before something like that can really be maximized. And what is the MOU? It has a lot of purposes, and it has a lot of things that it does. It documents the relationship. It sets apart responsibilities. It responsibilities in performance and evaluation and so forth. But I think it also is kind of important as a relationship building tool. When you have an existing relationship that's been going well and you're considering growing new programs or so forth, an MOU can be a great way to kind of take that to the next level and take a next step so that folks will be more comfortable. And it's kind of like, I like to see it as a mechanism for getting rid of uncertainty. But it's also a mechanism for creating and growing relationships. So that's sort of my concept of it. And that's what I'm kind of getting from what you're saying as well, well, Jason. Do you have any other perspectives on sort of the effective way to use that and to maximize the use of an MOU?
Yeah, I mean, I think it's also like anything else, it's a tool, right? So you can think of these things. I often encourage folks whenever they're doing an MOU development, project development, you know, it's a chance to engage the community and get feedback from the community and say, hey, we're interested in this. So I think about some of the health collaborations we've done, and they've always started with a community meeting. That's just the first step, right? And so I often think about something like an MOU as the endpoint, but what are the steps to get there and what other benefits can you gain from that process? And maybe it's increased community buy-in, maybe it's just greater knowledge of the need and what you're able to provide to address that need, right? So I think, you know, if just like in business, right, you're always thinking about, well, you know, no news is bad news, no publicity is bad publicity, right? If you're out there thinking about this, you know, let's say MOU around even something very basic like a flu shot drive, you know, can you use this as an engagement opportunity to talk to people about, you know, what are their concerns about vaccine hesitancy? You know, what are their unmet health needs? You know, hey, by the way, do you have a health home, right? Those are all the sorts of conversations you can have, even if you're trying to engage around a different topic. And so I kind of just see it as another tool to raise community awareness and sort of build deeper engagement with the community.
Thank you for your perspective on that, Jason. If you don't mind, I'm going to we're running short on time, and I did want, there was a topic that I did want to brush on this week. If we can go to 14, slide 14, please, Matt. And it's question 5. So collaborations in the COVID transition, with the end of the public health emergency on May 11th, we thought it would be good to divert a portion of the program to this, and specifically to addressing how this transition is going to impact partnerships and the collaboration environment for health centers. So if I could start with a question for you, Dr. Hiltz, and I guess this could be for you, Jason, too, whichever one of you feels compelled. But how are partnerships, either Dr. Hiltz, how are partnerships being conceptualized as a part of this transition, as in how partnerships are being used or thought of being used in a different or new way with the COVID health emergency being over? I was wondering if you could give us your opinion on that.
I guess we'll need a lot more than 3 minutes for this question.
I'm so sorry, but I really want your full opinion on this.
So I think there is, on our side, from the FQHC side, there's a little bit of anxiety around this state of emergency coming to an end with our COVID transition, because so much has been built around COVID. We've been able to acquire a lot of assets with COVID. For example, the mobile units themselves we purchased with COVID funding. A lot of the things that have been built into our programs now, like distribution of free vaccine, when we take the mobile unit out to the housing authority and other places, now that's coming to an end and it may cost going forward. It's just a lot of considerations around this. Mm-hmm. The flexibility that we have had because of the funding that COVID has brought to us. With that ending, we're still trying to really flesh out how is that going to impact collaborations. Will we not be able to, because for example, right now we have a whole team that's funded by COVID who goes out to do community outreach. So when that ends, do we have the funding to sustain those staff, the community health workers, those people that are going out for outreach opportunities? And how do we, it's a sustainability question for us. So I don't have a real answer, but I have the real concerns about how to make them lasting and how to continue, especially those that have been very successful. It causes some anxiety and fear that they'll just end.
Yeah, so it seems like I can't imagine how many moving parts there are there from your perspective, but it seems like the end game is still sort of uncertain here, that you have a great deal of assets that you can continue to use, that COVID has built real infrastructure for you, but it's not entirely clear what the limitations are going to be with funding going with program outreach going forward, if you will need to cut, or if you will cut, what should be cut. That's sort of the many questions that are this circumstance is presenting you. Do I have that understood correctly?
Yes, that's it.
Yeah, so appreciate your perspective on that. And before we're right at 3, Jason, I wanted to give you the opportunity if you had any thoughts about the end of the public health emergency in particular that you thought might be valuable to our audience.
Sure. Well, one is that we have, of course, the webinar coming up next Wednesday at 1 p.m. On that exact topic. And so I encourage folks to join us for that. I think it is an evolving topic. And I think, again, this is an area where folks have some anxiety, but it can also be a place to think about relationship building. So, one area is, hey, we're coming out of the pandemic, we're coming out of this, state of emergency. And, what are the ongoing services that we think are needed for the community? What are some of the things that we maybe have neglected over the past 3 years? Things like catch-up vaccinations for children, things like annual immunizations, things like just routine checkups, maybe dental care, all sorts of needs that may have just been put to the side. So, with every challenge is an opportunity. And I think this is a chance to kind of look at maybe a needs assessment for the community, just a listening session, a focus group with residents, right, to try and figure out what are some of the things that we just, haven't had the bandwidth to tackle because of COVID. So again, encourage you all to join us next Wednesday, 1 p.m. For that webinar, and hope to take a deeper dive into all those things then.
So I'll be joining the webinar. I'd encourage everyone as well. The material is always very high yield. But just to end on a productive note, I like the way you discuss this as the perfect timing to readdress needs and reassess needs. That healthcare and there are always emerging health issues. It's just a question of how quick we're able to identify them and address them. And if anything else, this circumstance does present an opportunity to readdress those, look at them closely, and think of more innovative ways to make our patients' lives healthier and happier. So I think if we have any other burning questions or things to mention, we'll allow someone to raise their hand and do that. But if not, thank you all for your time. Excuse the delay, and I hope you were able to take some concrete methodology from our session today. Thank you.
Apologize for my delay too. So
thank you for your
participation. I'm sorry about that.
No worries. Thank you so much for coming.
Thank you so much.
All right, thank you all.
Thank you. Thank you, Jonathan. I appreciate it.
All right,
Thank you.
See you all next week.
see you next week. All right.
Mhm.